Welcome! Thank you for joining us today for this Suicide Safety and Resilience training. My name is Vera Salzburn and I serve as Program Director for Safety and Resilience Programs in Chatham County Safety Net Planning Council. I'm also a certified Applied Suicide Intervention Skills Trainer. We have been working in Chatham County since 2017 in partnership with the Savannah-Chatham County Public School System, Gateway Community Service Board, and other diverse community partners. Together, we're implementing evidence-based training, including Applied Suicide Intervention Skills Training, or ASSIST, Safe Talk, Suicide Talk, Question Persuasion Referral, or QPR, as well as various resilience building workshops. While you are here as part of your mandatory job training, we would like to invite you to take care of yourself emotionally. The subject we are discussing today can be heavy and triggering for some, so please feel free to redirect your attention and ask for help if you experience overwhelm or acute emotional discomfort. Learning objectives for this session include: understand the impact of suicide in our community, explore how personal and community beliefs about suicide affect suicide stigma and safety, learn how to take the first steps towards suicide prevention, and contribute to suicide safety in the community. So let's begin with looking at numbers, statistics, which can speak quite loudly and help us better understand the impact of suicide on communities at large as well as individuals. First, we'll look at the bigger picture, national data on suicide, and then gradually we'll narrow it down to state and Chatham County level. According to the American Foundation for Suicide Prevention, suicide is the 11th leading cause of death in the United States. In 2021, over 48,000 Americans aged 10 or older died by suicide. The conservative estimate is that for every death by suicide, 25 or more people attempt. In 2021, there were an estimated 1.7 million suicide attempts. In addition to the tremendous emotional cost of suicide, there is also an economic impact in medical costs for individuals and families, lost income for families, and lost productivity for employers. Suicide is a public health problem and leading cause of death in the United States. Suicide can also be prevented. More investment in suicide prevention, education, and research will prevent the untimely deaths of thousands of Americans each year. This fact sheet reports 2020 data from the Centers of Disease Control and Prevention, the most current verified data available at time of publication in March 2022. Reportedly, 1,491 people died by suicide in Georgia in 2020. In the state of Georgia, suicide is the 12th leading cause of death. It is also the third leading cause of death for ages 10 to 24. Over 58% of communities did not have enough mental health providers to serve residents in 2021, according to federal guidelines. Over 4 times as many people died by suicide in Georgia in 2019 than in alcohol-related motor vehicle accidents. 49% of firearm deaths were suicides. 63% of all suicides were by firearms. Every study that has examined the issue to date has found that within the United States, access to firearms is associated with increased suicide risk. Guns are more lethal than other suicide means. They're quick and they are irreversible. About 85% of attempts with a firearm are fatal. That's a much higher case fatality rate than for nearly every other method. Now let's take a closer look at Chatham County, the community we live and work in. It is estimated conservatively that in 2021, 925 people attempted suicide in Chatham County. Reportedly, 37 people died by suicide. 7 of those deaths were by youth ages 15 to 24. Among those 37 people, 26 were men and 11 were women. Although more men die by suicide due to the type of means they choose, men tend to use firearms more often, women are 3 times more likely to attempt suicide. This compares to 39 deaths by motor vehicle accidents in Chatham County in 2021 and 36 deaths by homicide in Chatham County the same year. Each of those 37 individuals had family, friends, co-workers, and others who were impacted by their death. Suicide impacts us all as a community, and these numbers, these people, these lives tell us that we as a community have a lot of work to do in suicide prevention. So let's take a moment and reflect on suicide's impact in our own lives by thinking through the following questions. Do you know someone who died or might have died by suicide? Do you know someone who injured themselves with suicide in mind? Do you know someone who has or had, or whom you now suspect has or had thoughts of suicide? Do you know someone, including you, who is or has been personally impacted by suicide? In our suicide prevention work, we see that for many people, the answer to these questions is often a yes. It may be for you as well. For many people, suicide is that S word they tend to avoid. As a society, we resist talking about suicide for many different reasons. It could be shame and stigma, it could be the heaviness of the subject, it could be the result of a personal experience, or it could be unconscious. Many people avoid talking about suicide without realizing it. So why should we talk about suicide? Well, because talking about suicide is an effective way of preventing it. By opening the dialogue, sharing our stories, and identifying resources, we can reduce stigma and make it easier for people at risk of suicide to come forward and get the help they need. Before we talk about prevention methods, we'd like to discuss some false ideas associated with suicide. To help someone at risk of suicide, we need to separate myths from facts. That's why it is important to recognize these misconceptions. While there are many myths about suicide, we would like to highlight just 5 of the most common misconceptions. Number 1. People who talk about suicide won't really do it. This is false. According to research, as many as 75% of people who attempt suicide do or say something to indicate their state of mind and intentions before they act. Talking about suicide may be a plea for help for those people. Number 2. Talking about suicide may give someone the idea. This is false. Research confirms that asking someone about suicide will not put the idea in their head. In fact, many people having suicidal thoughts often feel relieved when someone asks. Talking about the possibility of suicide can be a first step in obtaining help. Number 3. People who died by suicide were unwilling to seek help. This is false. Studies show that more than half of suicide victims sought professional help within 6 months of their death. On a side note, as we are talking about suicide in the community, to help focus on the person rather than their action, we say that a person died by suicide instead of committed suicide. Number 4. If a person is going to attempt suicide, nothing will stop them. This is false. Most who attempt suicide remain uncertain of their decision until the final moment. Most suicidal people don't wish for death. They wish for the pain to stop. And number 5. Anyone who tries to kill him or herself has a mental health condition. This is false. Research shows that 54% of people who died by suicide actually did not have a known mental health condition, such as depression. It is important to understand that many factors contribute to suicide among those with and without mental health conditions. Environmental factors include financial problems, relationship problems, stressful events or loss, criminal legal problems. Historical factors include previous suicide attempts, family history of suicide, childhood abuse, neglect, or trauma. Health factors include chronic illness or pain, brain injury, mental health problems, and substance use problems. There is no one reason why people become suicidal. Instead, people become vulnerable to suicide due to a combination of biological, psychological, and social factors. People may inherit a tendency to develop a mental illness, for instance, or fail to learn how to cope effectively with stress for any number of reasons. People may also experience painful, disturbing, and traumatic events that overwhelm the coping mechanisms they have developed. The truth is that people who attempt suicide are in pain, whether it is emotional, physical, financial. They don't see a way out of their pain. They feel overwhelmed, lonely, and hopeless. So, our goal is to offer hope and to show that help is available. Most people who take their lives exhibit one or more warning signs, either through their talk, behavior, or mood. It is important to look for a change in behavior or the presence of entirely new behavior, especially when related to a painful event, loss, or change. Common warning signs include a sense of hopelessness, isolation, aggression and irritability, possession of lethal means, feeling like a burden, drastic mood changes, frequently talking about death, self-harm, engaging in risky behaviors, making funeral arrangements, giving away possessions, substance abuse, direct threats of suicide, and low self-esteem. When looking to provide support to someone who might be at risk of suicide, it is important to consider what we call the lethal triad. When there is an upset person who has access to firearms and alcohol or drugs, the risk for suicide tremendously increases. Being a helper means providing emotional support and reducing access to lethal means, as well as drugs and alcohol. Ultimately, helping a person at risk involves meeting their needs. The talk model can help you remember the steps when intervening with someone thinking about suicide. T stands for tell. Tell the person that you noticed a change in their behavior, appearance, or mood. Let them know that they can talk to you openly. Remember that your reactions and attitude can influence the intervention, so be patient, persistent, and respectful. A stands for ask. Ask the question, are you thinking about suicide? It communicates that you are open to speaking about suicide in a non-judgmental and supportive way. Ask them as directly, clearly, and as soon as you can. Asking in this direct, unbiased manner can open the door to effective dialogue about their emotional pain and can allow everyone involved to see what next steps need to be taken. Do not ever promise to keep their thoughts of suicide a secret. L stands for listen. Make sure you take their answers seriously and not to ignore them, especially if they indicate they are experiencing thoughts of suicide. Listening to their reasons for being in such emotional pain, as well as listening for any potential reasons they want to continue to stay alive, are both incredibly important when they are telling you what's going on. Help them focus on their reasons for living and avoid trying to impose your reasons for them to stay alive. K stands for keep safe. It is important to find out a few things to establish immediate safety. Have they already done anything to try to kill themselves before talking with you? Does the person experiencing thoughts of suicide know how they would kill themselves? Do they have a specific detailed plan? What is the timing of their plan? What sort of access do they have to their planned method? Do they have access to drugs or alcohol? Who else can be involved as an appropriate helper? The more helpers, the better. What other resources are available? Columbia Suicide Severity Rating Scale is a short questionnaire that can be administered quickly in the field by responders with no formal mental health training, and it is relevant in a wide range of settings and for individuals of all ages. If you'd like to get a copy, please visit cssrs.columbia.edu. Research has firmly established that family members of individuals who die by suicide, including parents, children, and siblings, are at increased risk of suicide. They are often referred to as survivors of suicide. Picture a suicide death as a pebble dropped in a pond. While the first and biggest waves hit the family and those closest to the decedent, the impact spreads outward to others exposed to the death, such as friends, witnesses, first responders, treatment providers, and colleagues. A suicide death can affect those beyond the immediate loss survivors and ripple outward, impacting others and even an entire community. Knowing your resources and where to find help is essential in suicide prevention and for promoting healing after a suicide death. An Employee Assistance Program, or EAP, is available for the employees of the Savannah-Chatham County Public School System. You can reach Lifestyle Management Group, your EAP, by calling 912-429-6981 or 912-429-2596. An EAP is a company-sponsored benefit designed to help employees and their families address problems that can compromise personal satisfaction and occasionally job performance. It's professional. Performance management counselors are fully licensed and professionals who have the clinical training and experience to help you and members of your family. It's confidential. Per state and federal law, your use of the EAP is confidential. No information will be shared with anyone without your written permission. It's free and informal. There is no charge to you or your family members for initial evaluation and brief counseling. If your problem goes beyond the scope of our program, you will be referred to resources that are covered by your insurance or based on ability to pay. If you or someone you know is experiencing thoughts of suicide, here is a list of free 24/7 crisis services to contact. Suicide and Crisis Lifeline. Their website is www.988lifeline.org or call 988. Crisis Text Line. You can text TALK or HELP to 741 741. Gateway Behavioral Health Crisis Center, located at 2121 East Duran Avenue, Savannah, Georgia. You can also call them at 912-417-9484. You can also visit your primary care provider, local psychiatric hospital, walk-in clinic, emergency department, or urgent care center. In the case of a student who has made serious threats to or who has attempted suicide, unless the attempt requires immediate emergency assistance, the parents should be called immediately and requested to take the child for assessment and evaluation by a qualified professional. If the parents refuse to report to the school or do not seek evaluative assistance, a report should be made to the Department of Family and Children Services. Campus police and the school social worker should be called for assistance, and the student should not return to school without documentation of a professional assessment. And now I invite you to please take a few moments and read the Child Abuse and Neglect policy on your screen. Thank you for completing this webinar in suicide safety and resilience. If you have any questions about this program, please reach out by email at assist@chlink.org, call 912-661-0577, or visit our website at preventsuicidechatham.org. Take care. Goodbye.